This program is brought to you by Emory University.
Good morning, everybody. Welcome to Heart and Vascular Grand Rounds for Emory University. My name is Brian Wells. I'd like to introduce our speaker today, who comes from Ontario, Canada, Dr. Amer Johri. He went to college at McMaster University in Ontario and then did his internal medicine, cardiology fellowship training, and as well as your medical school at Queen's University, and then went to MGH to do advanced echo fellowship and is now back at Queen's as a full professor of medicine. And his research interests include point of care ultrasound and carotid plaque for risk stratification, as well as cardiac care in the athlete. And he has multiple grants and publications in this space and has been very productive and is internationally known in this area. And I got to know Dr. Johri through our committees and councils in the American Society for Echocardiography, where he had multiple leadership roles, including the chair of the FASE Council or Cardiovascular Ultrasound Council for the American Society for Echo, and you were on the board of directors there. He is the founder of the Cardiovascular Imaging Network at Queen's, and he's going to present to us today, Shallow Vessel Diving Deep, How Carotid Ultrasound Predicts Risk. Welcome, Dr. Johri. We're delighted to have you traveling all the way from Queen's to present to us today.
Thank you, Brian. It's a pleasure to be here. And I just wanted to mention what a pleasure it's been working with Brian. So I was the chair of the ASC CAVIS Council for 3 years, actually, longer than usual. And Brian was my right-hand man, and now it's great to see him leading that council. So it's the Circulation and Vascular Ultrasound Council, and we chose that terminology to really reflect the importance of vascular biology and imaging in cardiovascular learning and patient care. And I think your center here with the heart and vascular seems to capture that same spirit of looking at not just the heart, but the vessels. And that's what this topic is about, where I'm looking at a particular vessel and really looking at how it can inform my cardiovascular practice. So it's a delight to be here and present this topic today. So I'm from Queen's University, which is in Kingston, Ontario, and I just want to situate you as to where that is. That's halfway between Kingston and Montreal on Lake Ontario. It's the Thousand Islands area, so that's where the salad dressing comes from. And it's also was the first capital of Canada. And we were one of the first, probably the only victors against the United States in a war back in 1812. But since then, we've been best of friends. So it's nice to be here. So I want to begin with this slide. It's one of my favorite slides. Let's see if it plays. As you may have heard of this study, it's just a fun study where they took some Egyptian mummies and scanned them, and lo and behold, they found atherosclerosis everywhere. So this was a little bit of a surprise because you think of atherosclerosis as more of a modern disease, but in fact, it's been part of the human condition. This is something we've been fighting for centuries. It continues to be very important as the leading cause of death. 17% of health expenditures, about half the population is projected to have some form of cardiovascular disease. And the costs are reaching billions and if not trillions. So how do we look at preventing disease? And this is where screening becomes more important. And in fact, the World Health Organization recently put out a call suggesting that non-communicable diseases and cardiovascular disease, which contributes most to non-communicable diseases, is the leading and growing cause of mortality across our planet. And they're asking us for to develop more detection methods. So we know that we can use things like the history, physical, and risk factors, and more invasive tools such as angiography to directly look for vascular disease. But there are some limits, such as cost, availability, and side effects. We do have tools, and I like this graph because it talks about increasing cost and invasiveness and the predictive accuracy. And as you can see, the more accurate you get with your tools, the more costly they are and more invasive they are. And risk factors sort of play a role in the lower end of the spectrum. There are some limits with these techniques, including cost, radiation, and issues with portability and access. So the Framingham Risk Score, for example, only identifies about a third of those who actually go on to have events. And when there are limitations, disparities can be amplified in certain populations. In Canada, we're very aware of the disparities in our remote and Indigenous communities and how we can better reach this population with screening tools to prevent outcomes. So the question I'm asking for my program is, can carotid ultrasound help within this risk stratification spectrum? So this is an example of a carotid artery. For those of you that may not be familiar, this is a long axis of a carotid artery. And what we're seeing is the intima, media, and adventitial planes. And what you can measure is the carotid intimal medial thickness, or the CIMT. This is an automated edge detection method that gives you the average height across a segment. In this example, you see a protuberant plaque, so you can also measure a plaque height. In any case, this method is radiation-free, less expensive, and highly portable. So the hypothesis is that this tool might be useful sort of in this context, perhaps not as invasive or costly as calcium scoring, maybe certainly not as precise as more angiographic methods, but may have a role closer to stress echo and risk scoring. So I became interested in this work and this tool from the ERIC study, or the atherosclerosis risk and community study, which was actually a CIMT study of 16,000 patients over 15 years. And as you all know, that this study showed that CIMT added important information beyond traditional risk factors. But what was interesting was that they also looked to see if plaque made any difference, and they only took a binary approach: is plaque present or not? And they found that if plaque was present, it significantly helped with respect to risk prediction in this population. There's also been other studies. There's been a meta-analysis conducted by INABA, which also showed that the presence of plaque compared to CIMT was significantly better at predicting cardiovascular disease, especially for 10 years. And so this prompted me to ask the question, well, if the presence of plaque is predictive, could quantification of plaque be even more useful? And when we look in the literature, there is some approaches to quantifying plaque. There's the plaque score, which is a semi-quantitative method. And what you do basically is you divide the carotid artery into 3 segments, looking at the ICA, internal carotid artery bulb, and the common carotid artery, both in the right and left. And you simply count the number of plaques in each segment. And if there's a plaque in a segment, then it gets a score of 1. So you can get a score from 0 to 6. So it's a semi-quantitative method. You can also get a plaque height and a plaque area, which the ASC guidelines refer and delineate how to conduct. But what we have to remember from these 2D methods is that plaque is actually a 3D phenomenon. So although you might see it as two distinct portions, it actually might wrap around in a plane that you don't see. And so you may not actually be getting the full picture of how much plaque is present. When our group thought about this, we looked at ways of better getting at the amount of plaque that might be present. And as Brian had mentioned, I had conducted my fellowship in Boston, where we employed three-dimensional methods for things like valvular assessment. What we decided to do was take those methods and apply them to carotid plaque quantification, knowing that this may have important predictive value. And so here what we did was we actually took a breast imaging probe, which is basically a two-dimensional probe that rotates within an internal rail and is able to generate a three-dimensional image. So we applied this breast imaging probe that was used to quantify cysts and used that to quantify plaque in a patient's neck. And using multiplanar reconstruction, we were able to come up with a volume. And we did this in a series of patients and showed that the multiplanar reconstruction and three-dimensional volume method for quantifying carotid artery plaque seem to have a better efficiency compared to two-dimensional plaques. And what I mean by efficiency is that we correlated this to angiographic coronary artery disease. At the present time, we're still looking at the efficacy of this test by looking at outcomes over 3, 5, and 10 years. We also came up with a plaque volume threshold of 0.09 milliliters that seemed to have the greatest area under the curve for predicting coronary artery disease. So this was interesting. And overall, what we were finding was that we know that just looking for carotid plaque helps predict risk. We think that measuring the amount of plaque is even better. And this really guided the next 5 years of research for our lab. And we formed this mission to bring plaque assessment and quantification into clinical practice. Now, this is not unheard of, where we, it's something that it has been building in North America, but the Europeans have recognized that plaque assessment is useful. So this is their recommendations for assessing arterial plaque burden using ultrasound as a risk modifier, and they give it a class 2A indication, very much at the same level as calcium scoring. So the patients that they might conduct calcium scoring for and benefit from this assessment may also benefit from ultrasound. But you can see that this recommendation is pretty vague. They don't really tell you how much plaque or where to quantify it from or what type of plaque, but they're recognizing that it's useful. So what we wanted to do was, how can we change North American practice and better define global practice using carotid plaque assessment? So this is something that I sometimes mentor with respect to early career researchers when they're building a program. You can ask these 5 questions, and that can map out your program of research for the future. What we asked was, how could we develop guidelines for the performance and quantification of plaque? Can we better define when it should be used? Which populations would benefit? And what are we exactly looking at when we look at plaque? Are there different types of plaque composition that might be better for predicting risk? Where can we use this tool, and who would benefit ultimately? And what about special populations? So I'll go through each of these areas in the rest of this talk. So the main thing that we wanted to do was better standardize the approaches to plaque quantification. When you look at the literature, different people are doing different things around the world. And so it was hard to group studies. So we wanted to start by coming up with a consensus that defines how to quantify plaque in general. And so we put together this group. I think you know many of these people from around the world who are experts in this area. And we came up with this plaque grading framework to simplify the approach and come to a common understanding. So we now grade plaque as 0, 1, 2, and 3. Grade 0, clean, no plaque, no IMT thickness. Grade 1, you're seeing a plaque that is less than 1.5 millimeters, and usually the IMT has not thickened. In grade 2 is a plaque that is between 1.5 and 2.5 millimeters. And then we really thought about the fact that IMT can thicken because of risk factors. And at some point, the wall becomes so thick, you can't call that intimal medial thickening anymore. At some point, you have to call that a plaque. So when the CIMT is going beyond 1.5 millimeters, we're also classifying that to be equivalent to grade 2 plaque. And then you have this higher category, which is grade 3. So how do we recommend assessing two-dimensional plaque height and thickness? It's important to begin with a sweep and a cross-section to first identify the plaque. And then what we're recommending is just measuring the maximum plaque height in an orthogonal view. You don't have to sum the plaque heights. You just take the highest plaque value. We've found this to be highly reproducible and to be a good predictor of cardiovascular events. So let's take a look at some examples. These are examples of grade 1 plaque. And here you can see the bifurcation, the bulb, the common carotid artery, the ICA, and the ECA. And there's a little plaque here. This plaque, when you measure its length, it's 0.15 centimeters or 1.5 millimeters. Area also happens to be about 5.3 millimeters square. This is another example here, and this is 1.3 millimeters, so it's considered a grade 1 plaque. This is a nice example of a grade 2 plaque where you have two very heterogeneous looking plaques, and you would just take the maximum plaque height in the maximal area of that to grade that plaque. And this is a nice example because you can have both protuberant and diffuse types of plaques. So this is where it gets a little bit more confusing, where the plaque can in fact extend all along this wall. So even this plaque is considered grade 2 because we're just looking at the height. You can see that the plaque area might differ quite significantly between these two patients. And we're still struggling with trying to figure out what are good plaque area threshold values that could predict risk. This is a nice example of plaque grade 3, where you have a very heterogeneous plaque. And again, you're just interested in the maximum plaque value. Here we have 2, and again, we're just interested in the maximum plaque height, and that gives you a grade 3 plaque grading. And then finally, if you have the interest and expertise, you can apply three-dimensional imaging. So now you can see that this three-dimensional image is very different than the one that I showed you from back in 2014 when we were using our breast imaging probe. As you know, now there's a dedicated matrix array, and I'm sure your lab probably has one of these probes as well. You can get exquisite detail of the plaque and really define where it's located. So how is this useful? I think it's good for defining where the plaque is, giving you an idea of the structure of plaque. Your velocities may not be necessarily elevated, but you can see that there may be channels through the plaque, and it could still be what's looking like a high-risk plaque. So that's why I think 3D is useful. The reason why I qualify that is because we don't have threshold volumes yet for what is a good volume that predicts cardiovascular risk. The other good reason to use three-dimensional echo is that if you're falling back on the two-dimensional height, the X-plane function can help you decide where the maximum plaque height value is. So for those of you that may not be familiar with ultrasound, this is basically two orthogonal views that were captured from a cube of three-dimensional data. So the two-dimensional line here is shown as a short axis here. So these are acquired simultaneously. And so depending on where you slice, you may not be at the maximal plaque height level. And the three-dimensional view helps you define where you are to get the maximal two-dimensional height in the long axis view. So that's one value of the three-dimensional acquisition. So in summary, we're thinking that application of carotid arterial plaque might be useful in clinical practice for a primary prevention tool, and also in patients that may have suspicious symptoms, but other non-invasive tests may not have found anything. And so in this guideline, we kind of propose how you can bring two-dimensional plaque quantification into your practice. What we're interested in is these low to intermediate risk patients. And what we're suggesting is that you could do a focused carotid ultrasound. So this is not the full carotid ultrasound, but a look to determine two-dimensional plaque quantification. If you have 3D expertise, then you can do that to get the 2D value as well, for example, by the X-plane function that I demonstrated. And basically what we're saying is that if you're grade 0 or grade 1, then that assures you that this patient remains in the low risk category. It's the grade 2 that can prompt you to consider that this patient is intermediate risk or high risk if they're grade 3. And then within the grade 2, we're also considering lesion modifying parameters, which I'll talk a little bit more about. So are there features that suggest that that plaque is vulnerable, and could the patient be vulnerable? And so would your risk stratification assessment change slightly? Now, remember, this is part of risk stratification. It's part of an overall estimate, and it's not done in isolation. You think about your other risk factor tools as well. And when you're sitting on the fence, some of these features could help move you from one direction to another. So what we're talking about is settling on simple two-dimensional methods from these guidelines as the recommendation, because they provide a quick, limited ultrasound for risk stratification. Now looking at when, I really wanted to define which population this tool might be useful in. And what we realized was that the low to intermediate risk population that is being referred for stress echocardiography may be a good place to look at the use of this tool and to study the use of this tool. What we found over the last 10 years using registry data is that two-dimensional plaque height, in fact, had a very good ability to predict 1-year MACE. And this is reaching almost 10,000 patients through our Institute for Clinical Evaluative Sciences. So this is in our province, all patients enter a registry where their outcomes are entered into a large database. And so we're able to look at their plaque height and compare it to cardiovascular risk outcomes and show threshold values and the ability to predict events. We were also able to show that grade 2 plaque seems to separate out these patients in terms of their survival over 10 years. And so what we decided to do was take this tool that on its own seems to separate out patients and add it to stress echocardiography. The reason why we decided to do that is because we found that of the 100,000 stress echoes performed every year in our region, 90% are normal, but those patients, 3 to 5% still have an event at 3 years, because as you know, stress echo is not perfect. So why are these patients misclassified? And could adding carotid ultrasound improve things? And so this is why we proposed a multi-center trial assessing the value of adding carotid to stress echo in intermediate risk patients. And this was funded by the CHR, which is equivalent to our NIH Institute. We do have an American center with Dr. Feinstein at Rush. So this is the trial. We're a third of the way through with about 500 patients and are hoping to recruit 1,500 low to intermediate risk patients. We're interested in those that have a negative stress echo and adding carotid ultrasound to them and following events in 3 years to see if the carotid ultrasound would have enhanced the sensitivity of the original stress echocardiogram. Currently, the interpreters are blinded to the carotid ultrasound assessment. And what we're doing actually is not just a carotid ultrasound to look for plaque and quantify plaque, but we're looking for something called intraplaque neovascularization, IPN. So that's getting back to further differentiating whether certain types of plaque might be more disease associated than others. And I'll talk a little bit about intraplaque neovascularization. So this is our carotid stress echo protocol. So you're familiar with your regular stress echo protocol where you take baseline images, peak stress, and then recovery. We've added a carotid ultrasound at baseline, and then we add a carotid ultrasound with contrast during the recovery. We do our plaque analysis, and we also look for intraplaque neovascularization. So why are we looking for intraplaque neovascularization? Well, this goes back to the inflammatory hypothesis of atherosclerosis. Can we detect an inflamed plaque by ultrasound? That's essentially what IPN is doing. And why is inflammation an important consideration? I just want to contextualize that a little bit now. As you might be familiar with the CANTOS trial, which was a canakinumab study showing reduction of events in a randomized controlled trial of over 10,000 patients, suggesting that the inflammation is an important important player in atherosclerotic cardiovascular disease. Also, the COLCUT study showed that colchicine helped to reduce events and lower the risk of ischemic cardiovascular events in patients who've had an MI. Again, speaking to the fact that there is an important inflammatory component to atherosclerosis and its sequelae. So the thought is that as a plaque develops, it may behave kind of like a tumor. So there's hypoxia, lipid accumulation, and inflammation, and this draws neovascularization from the vasovasorum to feed this ongoing process. But what's important to remember is that this new network of vessels is quite abnormal and it's friable. And this is why you get things like plaque rupture and instability. This would be a marker of plaque vulnerability, perhaps patient vulnerability as well. So that's why we're interested in looking for this. So the theory is that you can give contrast bubbles. And for those of you that don't administer this, these are basically lipid-formed gas bubbles that we can see on ultrasound. And the idea is that they can enter vasovasorum, and if there's a neovascularized plaque, we might be able to image them. And indeed, we can do this. So this is a carotid artery that we have opacified with a high concentration, in this case, of DEFINITY contrast. This black blob here is a plaque, protuberant plaque. And what you can see is this shimmering, and the contrast is entering through the vasovasorum into a neovascularized plaque. Plaque can be neovascularized to different levels. And what our lab did was develop a grading method for detecting plaque. So grade 0, none, grade 1 on the adventitial sides, and grade 2 bubbles throughout the plaque core. So this is a approach to semi-quantifying plaque. And my PhD student showed that the plaque score helped to predict outcomes as well in her group of patients. This work is not entirely new. Dr. Mulvey's lab in the Mayo Clinic, when she was there, also looked at adding intraplaque neovascularization to stress echocardiography. And they found that the best outcomes in their patients were those that had no IPN, whereas the poorest outcomes were in patients that had an abnormal stress echo and with IPN. This was a single center study, and so that's why, working with her, we've expanded this to a multi-center study, hopefully showing that this might be a useful technique to enhance stress echocardiography and risk stratification. In the next part, I just want to get into a little bit more experimental stuff, showing the breadth of work that needs to be done in this area. And as I mentioned, you can do that semi-quantitative method to look at bubbles within a plaque, but how can we better quantify this in a more objective manner? And so what we've done actually in our lab, this was a master's project, we did some tissue engineering to develop a plaque mimic and assess intraplaque neovascularization. What Christy Boswell, my master's student, did was she took some cotton candy and poured this into some molds with PDMS, and she was able to create a plaque sphere and then dissolve that sugar and create a vascularized plaque mimic, because those threads of that sugar approximate what a neovascularized plaque would look like. And this has been confirmed with imaging methods. So this is an interesting tissue engineering method that is used in other modalities and other types of research as well, when we're interested in looking at neovessels that might mimic intraplaque or intratumor scenarios. And so once we developed our plaque mimic, we embedded this and did an ultrasound scan, and we had different types of mimics with different types of channels and different tissue types within the plaque as well. And then we went ahead and gave contrast to our different types. And then using software and help from engineers um, back at Philips Healthcare, we were able to develop a time intensity curve to look at the amount of plaque enhancement. So for a early morning, I'm not going to go through all of these calculations, but just wanted to give you an idea of some of the breadth of work that can be done in terms of looking at quantitative methods of intraplaque neovascularization and how you can experiment and move further with respect to plaque assessment. Another area of research we're looking at is what we call a virtual histology of the atherosclerotic plaque using ultrasound. So here's an example of a plaque that has a maximal plaque height of 2.56, an area, and you can estimate the percent calcium of the plaque and percent fat of the plaque using the grayscale values. So we've developed a software program called IntelliPlaque that helps automate this grayscale median analysis and pixel distribution analysis. The way we did this was we worked with our surgical colleagues, recruited from their clinics, and following an arterectomy, took the plaques and embedded them and then conducted histology. And when you look under the microscope, you see some very interesting things. For example, foam cells, and this is what cholesterol crystals look like from these patients. And you can look at more advanced analysis using Halo, for example, which is a common software used in this type of analysis, and really identify things like thrombus, red blood cells, lipid cells, foam cells, and collagen calcium deposits as well within an atherosclerotic plaque. Why is this important? Because what we're trying to do is relate this back to our grayscale median analysis. And you can set the ranges to different levels of precision and try to match up and register what you're seeing on ultrasound to your histologic composition. The reason why we're doing this is kind of obvious. We want to develop a non-invasive method of conducting plaque composition using ultrasound and come up with ways of determining whether there are more vulnerable types of plaque predicting risk. And then finally, you saw that that was done in two-dimensional methods, but the next thing we're doing is trying to develop three-dimensional approaches to this type of analysis. So this is sort of ongoing work that hopefully I'll be able to publish and present to you in the future. So in summary, what we learned from this section is that atherosclerotic plaque is actually a complex process. The type of and activity of plaque seems to be interesting and might be an area of future patient selection and help drive precision medicine and help answer the question about whether vulnerable plaque features could even improve risk prediction further. Now, moving to where, in terms of how we can use this tool, I envision that we could be looking at using carotid ultrasound as a point of care technology. So some of you may be familiar with my work in POCUS over the last 10 to 15 years. We founded the POCUS Journal, and we've been looking at cardiac POCUS in all kinds of specialties and its use by non-conventional users. So we're kind of marrying these two pillars in our lab and interests areas of research where we're looking at whether carotid POCUS can help stratify risk. And what's interesting is that we've correlated these techniques using the handheld tools versus the full cart tools and found very good correlation when we're looking at simple measures. And as you recall, simple measures are being recommended initially by the guidelines. So this seems to be a promising area of further application. There seems to be a very good agreement for maximal plaque height and total plaque area for these methods. So the idea is that could office-based vascular POCUS be a reasonable approach? We do need to bring this in to more general cardiologist labs and application in a multi-center approach to come up with the conclusion that this is ready for real-time usage. We have, in fact, taught POCUS to emergency physicians looking at carotid ultrasound, and we are able to publish that, showing that that did help them decide whether patients were at high risk or not. Although we don't think the acute situation is the best area where this tool could be used. I think that looking at carotid POCUS as a primary care physician tool when they stratify patients for their long range risk would be the most useful. So here's an example. We have a woman of 65 years. She had an echo conducted for arrhythmia, so she had come to attention, has an intermediate Framingham risk score. Her LDL cholesterol level is 3.4. So this is, I know this is not the American units, but that would be considered borderline. She has no diabetes, and she had a screening carotid performed. By our guidelines, treatment is not strongly recommended. We wouldn't necessarily start statins for this patient. And so this patient may be overlooked and may not get treatment. There may be some uncertainty around this patient. When we do the carotid ultrasound, we find that the height is greater than 1.5 millimeters. It has a plaque score of 2. And our research seems to suggest that these thresholds are significant. So in fact, what some practitioners are doing, given the carotid ultrasound, they're using that value to help sway whether a patient should be on treatment or not. So in this particular example, this patient went on to be put on statin therapy. And it's not necessarily about beginning statin therapy. When you have an image like this, it really drives home the need for blood pressure management, lifestyle changes, glucose control, and smoking cessation, not only for the provider to push these techniques, but also for the patient. If they know they have an atherosclerotic plaque, literature has shown that they are a little bit more aware of their disease, and it may help them to adhere to lifestyle modification and medication. So I'm going to end there and just mention that we're very interested in looking at the use of plaque in special populations. I have a master's student who is employing the use of carotid ultrasound in for prediction of disease in women, and it may have slightly higher diagnostic characteristics compared to stress echocardiography. And then we're very interested in targeting our remote and indigenous populations. Quite often what we have to do when we want to stratify these individuals or determine the cause of their disease, they have to be flown out of their communities to a tertiary center. So what we're trying to do is bring ultrasound to these communities as a more accessible tool for cardiovascular disease risk stratification. And it appears that carotid ultrasound can play a key role in this regard. So I hope that my talk has helped move the needle a little bit in terms of bringing this tool to practice. As mentioned, I think we've done a good job with guidelines. I think we've done a good job with describing when it should be used the low to intermediate risk seems to be the highest yield. More work needs to be done. We have this ongoing North American project looking at its use in stress echocardiography. So perhaps this might be a new approach to stress echocardiography in the future, where you're adding anatomic data to a functional test. And then I think more research needs to be done with respect to plaque vulnerability. POCUS and automation is ripe for the future. Non-conventional users would very easily be able to get a plaque height, and then we can imagine where things like artificial intelligence could calculate a plaque composition right at the bedside. And then I mentioned the fact that we can also take handheld ultrasound into remote areas. And one of the final things that we're looking at is live streaming images from remote areas in a hub and spoke model to provide expertise right at the bedside when we're looking at patients who are getting a carotid ultrasound done for risk stratification. And then the last thing is that the role of artificial intelligence seems to have a great promise in this area, because there's so many features to carotid ultrasound, not just the quantification features, but also the composition features, and integrating them with the risk factors that you collect, the demographic data. You need a big brain to do this. And so this is where artificial intelligence probably will have a interesting role. So I'll stop there and take any questions, and I appreciate you listening to my presentation today.
Dr. Johri, that was a great presentation. Thank you very much for taking your time and presenting this. I have a question. When we are reading carotid duplex, a small percentage of patients we see less than 50% diffuse plaque in the common carotid arteries. And I'm wondering, can the location be also a predictor if the plaque is scattered in the common carotid artery, like proximal segment, mid segment, or in the bulb, or if the plaque is in the external carotid artery or internal carotid artery? And the second part is, when we look at the plaque, can the heterogeneity, like calcification or lucency and or fibrous plaque, can that also help in predicting the risk in these patients? Thank you.
Yes, great questions. Both questions are really good. So yes, the location of the plaque appears to have some importance. Both Dr. Vijay Nambi's work and my work has shown in separate populations that the plaque in the carotid bulb seems to be more predictive in those populations. And so in a sense, if you are only going to measure plaque in one area, the carotid bulb would be the highest yield, more so than the common carotid and the ICA. So that's what that literature seemed to have shown in the past. Now, with respect to your second question, which I thought was good, and now it just, so your question was about, oh yes, composition. So what we have done is looked at the heterogeneity of plaque, like you said, and asked that question, calcification versus echolucency, does it make a difference? So we think it does. There's a paper published by my colleague Herr, Herr, who's the first author, and she described that calcified plaque appeared to have more correlation with angiographic coronary artery disease. That's interesting because you would think that calcified plaque might be more stable as well, but it also kind of lines up with the fact that, you know, calcium scoring looks at the amount of calcification as well. So that work needs further outcomes assessment. So we're collecting outcomes over the long risk for that. But there is some indication that the heterogeneity of the plaque is important.
And our patients that we know have coronary disease being identified one way or the other is not of the same magnitude as it is in the coronary population. That is, we see carotid plaques, we see patients going to surgery. We think about whether or not it's a critical lesion or not from a standpoint of velocity. And I'm not sure what happens to these people, but I think they deserve a lot more than they're being given now as they move on from their bypass or their stent or whatever. And they have all this carotid disease up here. I'm not even sure it gets followed up enough. So I'm impressed with that as I see these issues.
Yeah, that's a great comment. Unfortunately, I think at that level, the horse has left the barn, so to speak, right? So what I want to ask your group, and I'm asking everyone, is why are we not doing this earlier and more often in more people before the horse leaves the barn? And it's inexpensive. There's no radiation. It can be done at the point of care, and it predicts risk over and over again. So why are we not using this more commonly as a screening tool? So I'm trying to focus more on prevention now in terms of my research and education before those patients end up in hospital and have events, because it's kind of too late for them at that point. So earlier detection and detection in the young, I think there's a global movement for that right now. And I was mentioning to Brian that I've been invited to sort of a global consortium that's looking at addressing what the World Health Organization is saying, is that this disease seems to be skyrocketing across the world. And sure, calcium scoring can help predict risk, but it has some costs and accessibility issue. So is there another test that could be useful for us to pick up this disease earlier? Remember, the carotid arteries, it's part of the same vascular tree. So if you're beginning to see disease in one part of the vascular tree, then more than likely you're beginning to see disease in other portions of the vascular tree. Dr. Fuster thinks that there are parts of the vascular tree that are early, sort of like the canary in the gold mine, I guess. They're earlier indicators. And one of those areas may be the femoral arteries. We've done some of that research in our population, and we found that seemed to hold the case for women, but less so in men. So we're still trying to tease that out in different populations.
It's fascinating, and this raises so many questions. I'll try to limit to a couple of them. One is you're comparing in your research the carotid plaque to stress echo, which seems like a bit of a stretch because and I guess it's the data you have, but I mean, it would be interesting to compare it to CT angiogram or something like that. See where.
Yeah.
So because we know from ischemia that the anatomy may be more powerful than the functional findings. So that was one question. I mean, statement or whatever. The other one was, since it is such a superficial artery, and that was the title of your talk, and you're focused on ultrasound. I mean, I'm just wondering, in plaque qualification, is there a possibility to do something like lipid, like near infrared spectroscopy or something? I don't know whether it would work, or some other techniques, or your echo techniques, as you point out, because what you'd love to see, if you're talking about younger people, you identify this, you don't really know events. Events take a long time.
Yeah.
So if you could show a regression,
Mhm.
improvement of those plaques with therapy, it would be a very attractive.
Okay, great
therapeutic
questions. So just to clarify, we're not comparing carotid to stress echo, we're adding it to that. So we have done comparisons in the past, and it was interesting. It wasn't the purpose of the study, but we found that carotid plaque had a higher diagnostic test characteristic than stress echo and nuclear for angiographic coronary artery disease. And so that was published in the 2014 paper. Here, what we're doing is we're adding it, so it's complementing. So it's not a comparison. So just to clarify that. And in fact, we are taking a subset of those patients and they're getting CT as well. So that we are going to be presenting that data. So we will be looking at that for sure. It's easy to do in those patients. And so what we're doing here is stress echo, as you may know, it's a very subjective assessment. Wall motion assessment is the hardest skill in echocardiography. And I could be sitting in an echo lab and I do this every day. And is there a wall motion there? Is this test positive? What do you think? You're not necessarily going to get agreement, right? So we know stress echo is not a perfect test. And how do we make it better? So there are different things we can do. We can look at strain. We could look at adding lung ultrasound. That's been, the different things people are looking at. What we decided to do was, why not add a quick look of the carotid artery, because many of our sonographers can do both. The machines have both a linear probe and a transthoracic probe. So it's a really nice opportunity to get extra information in the right patient, in that low to intermediate risk population. So it's just adding a few extra images without even expanding the length of the test, because we do it during rest and during the recovery period. So we're adding anatomic information. So it's not really that much of a stretch where we're comparing two different modalities. We're adding more information to the stress echo. We're not trying to replace stress echo. So thank you for mentioning that. And I apologize if that wasn't clear. Now, you mentioned that it's a shallow vessel, and that's a great point. Quite often when we're imaging a patient, through stress echo or nuclear, our patients are getting bigger and bigger, and it's harder to get good imaging done sometimes. With a shallow, even if a bigger patient, we find that there's less technical difficulty because you can still get at their necks. So it's nice in that sense that you can image the carotid artery in almost all patients. There's some patients you still have technical difficulty. So that's really nice about this test, that it can be done more easily than getting at the heart. And it's not replacing one test or another, it's adding additional information. Your information about getting more, your question about getting more information because it's shallow, we actually looked at doing that. And I presented this talk to your vascular group. And at that point, I had brought a lot of Hyperion data where we were actually looking at immune markers. And this was from segments and then correlating back to the imaging. So I do think that there is more information that you can get at from the shallowness of this vessel. I really like some of the ideas you mentioned. It's for further exploration that we would be looking at. So we are going down that road. The simplest thing of course, in younger patients is that they're not going to have plaque, but you can look at their CIMT still. So I still think there's some value of looking at thickness before plaque is formed. And I also think that there's also some, some looking at stiffness of the vessel as well. So using pulse wave. And so there is some benefit in looking at this in younger patients before they have developed plaque with respect to your comment there. Thank you.
Thanks so much, Dr. Johri, for an outstanding talk.
Thank you.
This will
Appreciate it.
conclude
Thanks for
Grand
the
Rounds.
question.
Everybody, enjoy the rest of your week.
Thanks.
The preceding program is copyrighted by Emory University.